I'll just jump right in. Glad to be here today and to really talk about what Family Foundation's Home Visiting is doing with developmental screening promotion. And I'm really going to focus on a continuous quality improvement project that we did back in 1819. And to be honest with you, I have a lot of slides and I have a lot of information. We have 30 minutes, so I'm going to jump right in and hopefully have some time for questions that you might have at the end. Also, Nicole did send out some of the handouts that I am offering to people. And obviously, after this presentation, if anyone has more further questions or would like more information or details, definitely be willing to contact me. There's is my email address. So Nicole, if you can jump to the next slide. A little background on who is Family Foundations, or what is it? We're a voluntary program that offers supportive services to parents and their children during pregnancy and throughout early childhood years. And here's kind of weekly visits are kind of an average of what we do. And these are all the things that we do. So we're really comprehensive as far as supporting children and families. And you can see that priority is child development and age appropriate expectations. So we really, one of our priorities is to focus on child development and support the family in that. Next slide, please, Nicole. We are driven by mission and vision. So our mission is to promote parent and infant and early childhood health and well-being in partnership with families facing adversity through home visiting support, information, and connection to the community. And I think that's important when it comes to connection to the community. We are just one piece of what family needs as far as resources. And so much of the work that we do in home visiting is making sure the family is connected to community resources that would help them. Our vision really is shared among all our other programs here in the state of Wisconsin, is that all families have a strong beginning to healthy, connected, and successful. Next slide, please. Who do we serve? We have a list of federal risk factors, and so here are them. Families do not have to have all of these to be eligible for the program, but we ask programs to enroll the priority of their populations that have at least 3 of these risk factors. So we have these, again, are some of the risk factors that are shared with other programs, and we really focus on families that have these federal risk factors. Next slide, please. Our funding comes from Maternal Child Health McPhee Funding Home Visiting. It's a federal grant, and part of accepting a federal grant is that they say that we must do evidence-based home visiting. So in the state of Wisconsin, we fund 4 of these models where the programs are operating in the state of Wisconsin: Early Head Start, Healthy Families America, Nurse Family Partnership, and Parents as Teachers. These are similar in all that they have a protective factors against child maltreatment and neglect. And so they all focus on that, again, with all the other focuses on child development and things like that. Next slide, please, Nicole. Where are we located? We do not fund all the home visiting programs in the state of Wisconsin. I know I saw Connie Dunlop is here with us, and she knows a lot about the other home visiting programs that are in the state of Wisconsin that are funded by other sources. But these are the counties in orange where we support home visiting in those counties. And again, they all operate one of those models. So we touch about half of the state with Family Foundation's home visiting. Next slide, please. So with that said, what we did with those programs in the state of Wisconsin we fund is that we did a continuous quality improvement project back in 1819. And it was to focus on this was the SMART aim that we did. 85% of children concerning ASQ3 screens receive targeted home visiting delivered developmental promotion by the next home visit, and then an evaluation by the early intervention to determine eligibility for services within 45 days. So that is what we were trying to improve, to make sure that if children had a concerning screen, mostly in the monitoring zone, that 85% of those children will receive some kind of home visiting delivered promotion at the next home visit. And then again, that we refer to early intervention with a referral if the screen determined that. So we were trying to look at this and make a change. Now, Nicole, I don't know if you're able to bring up the one document that is like a flow chart, and not the flow chart, but the, what do I want to say? It has the Smart Aim on it and all those. Are you able to bring that up?
Yes, just a moment. What was the title of it? Decision tree?
DSS, no, the DSS, it's the PDF.
Okay. Yes, I will bring that up and reshare.
That's great, thank you.
Mm-hmm.
So what I didn't share also is how many families we serve on any given day in Wisconsin. We have approximately 2,000 children enrolled in the home visiting program. Obviously during COVID, that's been affected a little bit. Our enrollment has dropped a little bit. We've been able to retain many of our families, but engaging with new families had come with this challenge with all the COVID pandemic. So our home visiting programs are slowly but surely learning how to navigate that with families and do early engagement with families in a different way. So I wanted Nicole to bring this up because I think what's important about our continuous quality improvement project is that it is a standardized framework that is evidence-based also on how to make changes. And this is the work that we did with the quality improvement project to make change again on the SMART aim. And so what this diagram shows you is that we have the SMART aim on the left. This is what we're trying to accomplish. And then there are 4 categories or drivers that say these are areas of improvement that we could look at. So we have standardized processes for developmental and behavioral screening. Primary driver 2 is effective program development connections with community partners. Driver 3 is competent and skilled workforce to address child development. And then driver 4 is active family involvement in children's development. So when programs were looking to improve this at their program level, they looked at these drivers and they would choose which ones they would want to focus on. Not all at the same time, but which one do we want to first focus on. Some programs did 1 driver at a time, some did 2 drivers, but again, they looked at the ones they thought that they wanted to address first to make those changes. And then in the middle of the diagram are the secondary drivers. So these are items again that could result in changing the primary drivers. So if we look at the first one about standardized and reliable processes, we could see that we could use different instruments, routine screenings, interpretation of the results of the home visitor knows about the family, and then timely and sensitive communication. So again, a program would look at these and say, let's focus on this secondary driver and see what we can change with that. Then if you go over to the last column on the right, you see ideas to test and change concepts. So these are actual hands-on things that the program can change and are the real hands-on things that they would do. So if we look at those items, we see a policy for protocol for screening, administration, scoring, interpretation. And we talk later on today, you'll see an example of what somebody created then to help their program change their processes for developmental screening. And so, Nicole, I don't know if you sent this one out. I don't know, but we can share this out with the group after the presentation because I think it is a good indication of how we approached our quality improvement program, and it was a very organized, systematic way so that programs could have success in this. And again, this is good information if any program is looking like, I want to improve how we do our screening. This ideas, these can be used and as we say, shamelessly stolen and used in another program. So, okay, thank you. If you could go back to the PowerPoint slide. So as I kind of talked about in the screen, these were improvement changes that were tried and adapted. So these are the ones that people used and then they have adapted them. So the primary driver one is standardized and reliable processes for developmental and behavioral screening and surveillances. And the decision tree that I know that Nicole sent out is one of the ideas that was tested and then adopted by the program. And the decision tree really is this kind of flow chart that just kind of gives decisions along the way. Many of the programs that entered into the CQI project found that they kind of had some decisions on how they were going to do, but it really wasn't standardized, and to move in the same direction to make sure that every time a parent and a child is involved in an ASQ screening with a different home visitor, that the process didn't look different, that it looked the same. As we have a retention of home visitor is better, but we had an issue about 2 years ago when this was happening of we had a high turnover of and retention of home visiting staff. So you could see why a decision tree could be a useful tool because again, if a home visitor goes into a training and knows all about ASQ, but they don't have the process down, this makes sure that it's reliable for a new home visitor to follow the flow, and that every family is guaranteed a similar and approach to the ASQ screening and decision. Policies and protocol for appropriate follow-up based on screening results and our parent identified concerns. What was adopted by some of the programs was an ASQ summary sheet to share with parents after screening. So again, it was a sheet that when the parent was given the ASQ, and then the next time the family would meet with the home visitor, that they would have the summary sheet filled out for the parents. It would reflect what the parents' goals were, what their ideas were, what the concerns were. And then it really documented what they were going to do next, right? They were going to rescreen, they were going to refer, the referral was accepted, the referral was declined at this time. So it was a way to document decisions that were made based on the ASQ summary. Next slide, please. If we looked at the primary driver 3, competent and skilled workforce to address child development, some of the programs adopted and adapted motivational interviewing training to promote successful referrals to EI. So what was identified in this part of the CQI project is that many times home visitors felt that this was a difficult conversation to have with families, that families many times were hesitant to enter the conversation about concerning screen for their child. And so motivational interviewing is, again, an evidence-based process and way of asking questions and supporting families in changes for themselves. So many of the programs have been trained in motivational interviewing, and they worked on using that skill set and that approach in supporting families to understand and then agree to referral to early intervention. Primary driver 4 is active involvement in families' child's development. And one of the approaches that was adopted by a program is that the home visitor reviews the ASQ form with the family on the visit prior to when the screen will occur. The program had found that sometimes the families could benefit from this idea of what's coming up next, the family then was able to be more observant of their child during that time, looking for what maybe the ASQ questionnaire might be asking them. And the family was much more engaged and ready to kind of look at the ASQ and say, oh yeah, I saw my son do that, or oh yeah, just this morning my daughter said this to me. So they found that kind of getting ready to do the ASQ with the family was a good approach on having the family engage with the form and being, again, more observant of the child development. Now, these are just examples of what was done by the programs. We have a really long list of other things that programs did, but I just wanted to kind of give you examples of some of the changes that were tried and adopted by the program. Next slide, please. So after the CQI program, and then kind of grounded in what's important, we have now expectations and best practice guidance that we have given to the programs to say, after the CQI project, this is what we really expect programs to be doing as far as best practice. Again, based on more than just you're required to do this, but this is our best practice. So caregivers giving education about milestones and tips for supporting development by the first home visit after the birth of the baby. So it's, when do you start? It is really at the beginning of the birth of the baby, that we don't wait until something comes up on the ASQ, that this is something that is happening first and foremost, and parents understand that understanding and supporting their child's development is one of the key focuses of home visiting. At the developmental surveillance level, each home visitor is asked the client if they have any concerns with their child's development, behavior, or learning. So at every home visit, the question is given to the parents about if they have any concerns about their child's development. And again, depending on what the answer is, the conversation can go differently with different families. I think one of the things that we have observed during this is that many times the families have a concern about a child's behavior. And so then the home visitor is able to pivot to many of the developmental milestone materials from the Act Early, and to really help the family understand behavior and whether or not what they can do to support the child's behavior, and maybe being a more positive approach versus maybe a negative reaction that the child is doing. Next slide, please. So another expectation and best practice is that we have a timeline that all ASQs must be done for every child that's enrolled in the program. These are the requirements for family foundations, home visiting. They might have different expectations for their evidence-based model, but these are the minimum that each program must do with children if they are contracted with us. So we have to complete an ASQ by age 6 months, and then at ages 9, 18, 24, and the ASQ 2 completed at least by age 6 months, and then 12, 18, and 24. We have some of them parameters around that. We share the ASQ results with the child's primary care provider if the family provides a release of information. And we have found that many programs have really stepped into this and are sharing information with their primary care provider. And many times it's not just when there is a concerning screen, but they're sharing all results with the screen. And so the primary care provider knows that these screenings are occurring. We require that rescreening within 90 days if the screening results are within the monitoring zone. So again, not only is the family receiving information all the time, but if it is a monitoring zone, we rescreen in 90 days. And then that determines whether or not it's continuing monitoring or if it has fallen into the referral zone, or if it has, with the developmental promotion, it has changed and gone into age expectation. Refer to the birth to 3 program for evaluation if the screening results are within the referral zone or a parent has a concern. So again, we're asking at every visit if the parent has a concern. That might prompt a referral to the early intervention program, but definitely if it's in the referral, parents home visitings are receiving permission from the birth to 3 to refer their child to the birth to 3 program. Many times it could be either the home visitor supporting the family calling them themselves, or they might call on behalf of the family. That's kind of decided at that family level. And then again, we provide, home visitors provide developmental promotion related to concerning results by the next home visit. So if there's a monitoring screen done in the area of language, then the home visitor is providing directed developmental promotion ideas to the family about language at the next visit. So, time for questions. I did all of that in 23 minutes. One of the results that we also found from the home visiting program that I think is really important, and I think is continuous challenge and something that we strive for in home visiting, is that local relationship with the birth to 3 program and the home visiting program. When we were in the continuous quality improvement project, we found out that many times home visitors didn't really know who the birth to 3 program was. They knew about it and they knew the referral number, but they didn't really know the people on the other end. And vice versa, many times when the birth to 3 program was receiving a referral from home visiting, they didn't really know what home visiting was and how that was connected to the family and how to work together. So we had some brighter spots from some of the home visiting programs and counties that were able to form those close relationships, and they got on first name basis versus, Terry over there in the home visiting program. And we saw tremendous change when that was a first name basis program. And I think Manitowoc is probably one of the best programs in the state around that. And I don't know if any of you know much more about Manitowoc area, but our home visiting program is through Lakeshore Cap there. And they have a really community approach to referrals anyway. So referrals come in and they, at a community level, are talking about where to support that family. And our home visitors know the physical therapist in the birth to 3 program by first name. And they have common goals and strategies that they're sharing among themselves on behalf of that children and families. So I think that that's a program that we often refer to as they got it, because it's not about them. It's not referring families to something, it's bringing programs into the family. And they have been very successful in supporting families in home visiting and in birth to 3 and other programs that the family resource centers that they bring in for that family. So that's kind of our North Star. And we are continually just striving to improve our developmental screening and promotion and referral. We find that not many of our referrals are happening after a concerning screen. And so we're diving more into that. And what we're doing currently right now is that we have a survey that goes out to our home visitors every year, and we ask certain questions to them. And we added some questions this year about how much do you know about your birth to 3? Do you feel confident in referring a family there? What has been your experience? So we're trying to get to that, again, that personal level of why or why not would a parent maybe decline a referral to birth to 3, or why is that happening? And you can we go back to that motivational interviewing, right? That concept is that change is difficult for people. And if we apply a certain way of approaching that, we can support people that need to move through change. And I think a referral to the Birth to Three program is a change for families, and it's a whole level of understanding and acceptance. And how can we, so if an example of that is if a home visitor doesn't know much about the Birth to Three program, or maybe even doesn't even know if it'd be helpful, if the family says, nah, I don't want a referral, you might say, oh, okay, parent declined. End of story. We don't know if that's what's happening, but that's what we're investigating next, is where is that when parent says no, and they don't want that referral, what's behind that no, and can we change those no's to yeses, and have that successful completion to a screen that is utilized to identify a concern into evaluation where we can validate if that concern needs additional support. So we're kind of diving into that to see if we can shift that even more.
Anne, do you have a question?
I have a real quick 2 comments, but thank you, Terry. I think the point you just made about the personal relationship or getting to know the programs is important. And I know they don't spend as much time with the clients as home visitors, but the WIC programs that we've been working with to train them to do better serving kids with special needs. When we were more in person, actually, before COVID, when they were making those connections with the regional centers and the Birth to Three programs, the WIC nutritionists got on that first name basis. That's what struck me about what you said with their local programs. And it made a huge difference in the referrals and the way they were able to represent those referrals. But the other point that, because this started, I don't know, more than 10 years ago for the WIC nutritionists, that there's a lot of turnover. And so you have to keep that up. So I guess the other point I wanted to make is that it's really great if a program reaches out and you can start to see people that, oh yeah, I know that person over at the regional center. She's great. And, they start talking that way, but then the next generation, if you will, of people in that program in that county need to then also do the same thing. So it's just sort of a constant thing. It's not like once that program's established the relationship, it's done. Yeah. So that was just my comment.
No, and I really well taken, and that's really, really true, because one of our programs that focused on that during the CQI project, the home visitor left her position right after that. So matter of fact, before she could make a presentation about what she did. So yeah, it really, really well said. And we even, there was some changes in Milwaukee County Birth to Three program. And so that's such a large system, right? When we talk about Milwaukee County, there's numerous home visiting programs, there's numerous providers of Birth to Three. So we did have, before COVID, we had one meeting. We need to get back to do a virtual with them to really talk and understand and start forming those relationships. So I think there's big system support. You're right, Anne, and that small. Yeah.
And on both sides. Yeah. The change could happen, or the person could leave.
Yeah.
Terri, one of the things that I really liked about the Continuous Quality Improvement Project as well was just the way in which it helped the programs and the program staff who were there start to build a set of practices and attitudes and approaches that would allow them at any given point in time to say, well, what might be the cause? What might drive change? What could we test and change out or test out? How do we watch our data to see if it's helping or not helping? So I wonder too whether that really lasted, that sense of understanding how to test change, and that can certainly help as you start to bring in and fold in new staff, maybe.
Yeah, I think what we're doing as a program is that we're gathering this new data through the fact study with the staff, and then we're going to go back and relook at our data and re-engage our programs in this idea of ASQ and what we're doing. And again, some things shifted right through COVID because we were doing virtually, we were doing them, and some of that change was actually really positive because then it was more about the family knowing about their child's development versus the home visiting, observing it while they were there. So I think there was some positive things, but you're right. Gail was one of our faculty and she was in the room very often when we were discussing with home visiting programs and getting through all of that. But data is an important part, and we have data that we can use And we have specific data now about ASQs. And we're tracking which ones are due, which ones are happening. Programs can track in our data system how many needs referral, what are in monitoring. So we have really detailed information about ASQs now.